Thank you, ladies and gentlemen. I would like to convey my very sincere. Am I audible?
Yes, sir.
Yes, sir, you are audible.
Okay.
And the screen is also
Okay.
visible.
At the outset, I would like to convey my very sincere thanks to UP IAP and whole of the Lucknow IAP, and especially the flag bearer, Dr. Ajay Srivastava and Dr. Praveen Kumar, being the key opinion maker of this workshop. And I am witnessing the last 2 days as well, the whole of the workshop. It fantastically planned, meticulously exhibited, and hope in the subsequent 2 more days and one practical training is also there. Hope the workshop will definitely suit to the demand of general pediatrician in office practice. It will be very, very helpful. Lot many things have been discussed regarding the instrument, regarding the anatomy, regarding the physiology, regarding the normal waves, regarding the abnormal waves, and not many things. Dr. Anup will be addressing you on the artifacts. My talk has been, I have crafted this whole of the talk to practical relevance. The as soon as the child comes to you in your clinic, your role is to at least reach to conclusion clinically that what you are dealing with, and then justify your approach for demanding EEG. And therefore, it is very, very important that not every movement is seizure and not every movement requires an EEG tracing. So the aim of this talk is to learn EEG through case scenario, especially focused to the office practice, and I will give a brief of electroclinical syndromes, and that is very, very important. First comes the clinical and then comes the electro, and therefore it is very, very important for we practitioner, because the pediatric OPD is a huge rush. You have to see a seizure patient, you have to see the diarrhea patient, pneumonia patient, vaccination waiting. There are a lot of administration issues also. So it is very, very important to clinically reach to a conclusion that yes, you are dealing with such case and what you are expecting in EEG. And therefore you demand EEG and you see that changes what you have expected. The further technicalities in understanding the EEG. And the sequence of recording, as we have last 2 days have been flooded with all the sort of information. It should have an awake, it should have an activation procedure like fatigue stimulation, hyperventilation, drowsy state, and sleep. And we also know that there is a limitation of the EEG, like lack of sensitivity for epilepsy is there, even epilepsy is there, but the tracing is normal so many times to the tune of 20 to 30%. Lack of specificity, epileptiform abnormalities are not strongly associated with epilepsies, and we have EEG is prone for misinterpretation, especially if we are not tuned to train to pick up abnormalities, nor our technician is so trained, not our machine is good. So this is a really hampers our interpretation. We know that EEG sensitivity in epilepsy, it is very, very important that standard wake EEG has chances of picking 50% of abnormalities and 50% of normal tracing. That would means the abnormality is there, but EEG is not able to pick up to the tune of 50%. Sleep EEG, yes, there are chances of picking more, that is the 80% abnormalities and 20% normal. Repeat EEG, the standard, and especially the sleep EEG has a higher pickup rate to the tune of 92%, and 8% normal changes can be seen. This is why does EEG lack sensitivity. I will not go into details of that. We know that it is only we are placing the electrode over the scalp. There are so many structures which are distant from the scalp. and epilepsy is episodic. Not always you get the discharges, and this is important facts we should remember. Regarding the indication, why you want to order an EEG? Yes, to confirm that this abnormal movement the child is exhibiting is not a non-epileptic event. It helps in the specified syndrome, as we have discussed that there are so many very classical electroclinical syndromes, and then we have to predict the seizure recurrence, we have first unprovoked seizure, we have status management, status epilepticus management, and so on. These are the classical indication where we perform the EEG. Why should and how should we done? But how should EEG be done? It should be done as early as possible after the seizure. Sleep deprivation is again very important, especially before above the 2 years of age. The pickup rate is more. We have to all activation procedure should be there. Omission of anti-epileptic drug prior to EEG is not recommended. And here is a patient in front of you in your clinic. Is a 11-month-old, and he was a playful, and there was no focal deficit, and is a normal development. The elder Sib had a history of 3 typical febrile seizure from the age of 1.5 years to 4 years, and is now at 7 years of age. His aunt had also an epilepsy, and here is the patient in front of you. So what is your diagnosis? What is the chance of recurrence of febrile seizure in this patient? And somehow EEG was done on the parent request, and it depicted few discharges as well. And the patient was thought to be having some epileptic event, and Valprin was started. So your comment. So here what is as soon as the patient comes, it is all the immediate management you have to do. But as a pediatrician's role, you have to simultaneously, you should know or you should counsel regarding the risk of recurrence. That is, what will be the risk of recurrence in subsequent. Definitely by the history, it is a simple febrile seizure, though the family history is also there. But he is having a there's no normal, no neurological deficit. There's no other problem excepting high-grade fever, and I had a convulsion. And also there is a second important thing, assess the risk of epilepsy in this patient. So these are the very two important point to consider for a pediatrician, that a child who is convulsing in front of you, apart from managing the acute seizure, simultaneously you have to ask the risk of the recurrence and the risk of the epilepsy. Let us see, this is the risk of recurrences. If the child is having an age of less than 1 year of age, is a child is having a positive family history of febrile seizure, his febrile seizure was occurred at a very low temperature, maybe 100, 101. Febrile seizure was just after a short duration of fever, 3 hours fever, had a seizure. So these are the risk factor which can predict you the future recurrences. Let us see. If there is a no risk factor, even though there are chances of recurrence to the 4%, if there are 2 risk factor, there are chances of 32%. And if there are 4 risk factor as it is depicted, they are having a chance of 76% of the recurrence. Now, if he is having a family history of epilepsy, but he is also having a neurodevelopmental abnormality, is a delayed in development, there is a developmental delay, having a complex partial seizure, complex febrile seizure, more than one complex. So the risk in general population without risk factor is 0.5%. And after first febrile seizure, there is a recurrence of 1%, one factor 2%. And if all the factors combined, there are chances of 10 to 15% of this patient turning into the seizure. So EEG in febrile. Then what are the indications? When we are going to do the EEG is EEG has a limited role. There is no classical EEG pattern in the case of febrile seizure, as we see in electroclinical syndromes. So You by EEG, by doing the EEG, you cannot predict the recurrences of the future seizure. By EEG, there is a you cannot predict that he is going to have a afebrile seizure. By doing EEG, you are not going to predict the future epilepsy. So why to do? This is very important. Clinically reach to a conclusion that you are dealing with a case of symposia. And Dr. Ajay, in the first day of his opening remark, has beautifully illustrated the case. That's why I've kept this. So EEG should not be a part of routine evaluation in neurologically healthy children with a simple febrile seizure. But definitely, indications of EEG is there if suppose this patient is having a complex febrile seizure as it is depicted in the video. He is also having the focal seizure, and it is a recurrent febrile seizure with developmental delay. These are the clinical situation where you can advise EEG for so that the future recurrences, future epilepsy can be seen. Another case is in front of you, 3-year-old with 2 episodes of you are seeing the seizure. Was first for 6 months ago, were playing happily, banged her head against the table. She didn't lose her consciousness, no bruise, no injury mark. Mother picked up the baby. Baby became pale, floppy. There was a stiffness which persisted for a minute. Then she recovered and slept. Second episode, another incidence of hitting over the head while playing. Attack was similar to the first. No history of epilepsy, neurodevelopmental normal. So would you like to do an EEG? The video is in front of you. He presented with a tonic spasm, such of thing, but definitely there was a provocation, there was a breath holding spell. So the history is very important, and if the patient is bringing video, and that clarifies that yes, you are not dealing with a seizure event. But suppose if the child presents with you without any information, without any video, the patient is saying that there is a tonic spasm is there is no history of banging and all, one has to think on different line. And hence in clinical practice, it is very important to ask the patient to bring home video so that most of the thing will be clear. And by seeing the video, by seeing the phenomenology, you will semiology, you will be absolutely clear that what the patient is under. Then what is EEG specificity? It has to be very, very important that 10% of the children without epilepsy will have abnormalities on the EEG, and therefore clinically we have to correlate. So this patient had a diagnosis of reflex anoxic seizure and treat the condition and not the EEG. This is a very, very important, and even if the EEG is showing some discharges as well. Now another case, a 4-year-old child with a history of seizure for last 4 months. He had multiple attacks. Semiology of generalized tonic-clonic seizure, and absolutely unprovoked episode was there. Routine investigations were normal. EEG was done, and it was also turned out to be normal. Then the question is, and the parent is in front of you, you have to counsel that, is the child is having an epilepsy? Yes. Now you have to say go to the basic definition what the seizure is, and we know that when a small number of abnormal neurons undergo prolonged depolarization, impulse is a wave of depolarization and associated with rapid firing of the repeated action potential. That is the impulse, that is the epileptic seizure, repeated attack of potential action potential. What is epilepsy then? It is a group of disease characterized by a recurrent unprovoked seizure with above 24 hours gap. So this is another important. And what are epilepsy syndromes? Epilepsy syndromes, you can say Hindu, Muslim, Sikh, Isai. We have every caste has having a different culture. So in this epilepsy syndrome, we have a different sort of presentation. A group of child with West syndrome will have a different sort of presentation. A group of patient with benign childhood occipital centrotemporal will have a similar sort of presentation, and this is what is known as the epilepsy syndrome. So it is very important that to this patient was having a seizure 3-4 times. Afebrile episode was, though EEG was normal, but definitely we will like to repeat EEG because this is a history which is favoring the chances of afebrile episode several times a day, GTCS, definitely some sort of epileptic seizure must be there, and repeat EEG is considered. So all normal EEG reports cannot rule out epilepsy. That is a very important thing. And yield of the EEG improves within 24 to 48 hours. And repeat EEG have a definite chances of higher pickup rate of the epileptiform activities. Another patient, she is 8-year-old girl with history of episodes of sleep, that seizure within the first hour of sleep, facial deviation, grunt-like syndrome, clonic movement was there, had 2 episodes in the last 8 months. Awake EEG record was normal, and as you are seeing that this patient was offered an EEG, but at the time of the day he was all awake. It was absolutely turned out to be normal. So what was the mistake? This, when the provocation was done, when the awake come sleep record was taken, and it was seen that it was a case of centrotemporal spike, which is increasing. So therefore, it is very, very important to counsel, to advise the EEG technician, to advise the accompanying parents at what time EEG and what situation EEG should be done. Similar patient having a facial seizure, lateral deviation of the eye, hemiclonic movement, drooling of the saliva persisted for 2 minutes during the night time only, and EEG reveals the bipolar, the discharges we seen in the centrotemporal region. And the classical EEG in Bex, this is the signature EEG in Bex, is the high amplitude discharges are there. Maximum expression is over the centrotemporal area. It could be a bilateral and it could be a unilateral as well. Though the seizures are unilateral mostly, activated in the sleep, and it have a normal background as you are seeing here. Now this is another same patient of bats. You are seeing the discharges coming from the centrotemporal region, and these are the mutation of the genes which are responsible for, and these are the Rolandic spikes endophenotypes, where you can see the Rolandic spike in the Rolandic epilepsy, ESEs, ESCSWS, autism, and ADHD as well. And we know that it has an excellent prognosis. AD can be avoided, and carbamazepine is frequently used. Another patient is in front of you, 10-year-old patient, frequent blank spell was noted by the school. There was a recent worsening of the scholastic performance, possibility of absence epilepsy was concerned, and awake record was done in this patient. Do you think that this is a seizure or a seizure mimic? Definitely, you are seeing a patient who is having a behavioral arrest. There is sudden blank spell is there. So if yes, why and what type of seizure do you consider, and EEG is indicated or not? This is a very important practical question, and hyperventilation is a very important criteria for the manifestation of the seizure activity, as in this child who is hyperventilated for 3 minutes, and the EEG you are seeing the 3 spikes and wave. This is a very classical signature EEG of childhood absence epilepsy. And if a patient comes to you in your OPD, says that he's a frequent blank spell, try to ask the patient to do hyperventilation for 3 minutes. Your diagnosis will be confirmed in front of you in your OPD, and later on you can confirm by signature EEG. And this is a very, very practical. This is the only epilepsy without any investigation. You can confirm in your office practice that yes, she is a case of childhood absence epilepsy, though you can confirm later. So this is a type of a typical absence is there, and electroclinical syndrome is a childhood absence epilepsy. And this is again a video of childhood absence epilepsy. You are seeing attacks of the absence, and you are seeing the discharges, which are mainly from the frontal region. You can see. Here is another patient who is having a behavioral arrest, and is having for few months, lasted for few minutes, though no family history of seizure. Neurodevelopmental child was normal, and he used to be awake by pinching. So there is no, sir. The hyperventilation was done. Nothing was clue was there, and MRI reveals nothing. EG was absolutely normal. So on this was a case of daydreaming, and you can see that this is a patient from a remote place from UP came. He was shifted to some madrasa of Raipur, and he was sent to me. And home video was there from madrasa, and you can see that the parent was disturbed. Febrile was not associated with the child and had a lot of family problem, and this is actually a psychological stressor, and EG was absolutely normal. So this is a case of so it is very important. The family history, eyewitness account of the event is important, as in this case and in any case. Eyewitness account, you are going to clarify the disease process very nicely. Another patient in front of you, sudden jerks with flexion of the limbs. He had a severe hypoglycemia, and everybody would agree that you are dealing with a case of infantile spasm. And definitely, we want that EG should be done, and EG was done. And you can see this high voltage, irregular asynchronous wave was there. This chaotic pattern and hips arrhythmia was there. So this is a classical of the infantile spasm or Best syndrome. And another video you are seeing here is you are seeing here is a high voltage asynchronous slow waves are seeing here, and flattening of the background activity superimposed by a low voltage fast activity is seen in a typical spasm. A burst suppression is seen in this patient. So this is a very, very important. And this is another patient of West syndrome. And we know that a lot of now genes have been come up with the West syndrome. And don't afford to miss the presence of cardiac rhabdomyomata in patient of infantile spasm. Here is a patient with tonic spasm, focal partial seizures was there, and this is a classical of Otahara. Seizure begin before the 3 month, and the EG is very classical. You are seeing a burst suppression. You are the classical high voltage burst is there, and with a relatively flattened background is there. A lot of genes has been implicated in the Otahara syndrome, and you have to differentiate whether you are dealing with the early myoclonus encephalopathy or an Otahara. You are seeing here the classical presentation of Otahara. There is a continuous burst suppression is there. There is a discontinuous pattern is there in early myoclonic encephalopathy. Tonic spasm is seen in Otahara, whereas the myoclonus is seen is there. And there is a chances of a structural lesion is seen in as a etiology in Otahara, whereas the metabolic abnormalities are seen in early myoclonic encephalopathy. Another patient in front of you, early myoclonic jerks are there. EG reveals the presence of polyspike discharges. You are seeing here very classical generalized paroxysmal patient of generalized myoclonic epilepsy. You are seeing the photosensitivity is very, very important in this patient. Another patient who is having a focal febrile seizure, had a first DPT vaccine, recurrent focal provoked seizure. Then since then, he had a myoclonic jerk and a static milestone, and birth history was normal. Family history of febrile and afebrile seizure was present. This is a classical presentation of a severe myoclonus epilepsy, or you can say it or as to be a Dravet syndrome, usually seen in the first year of life. It starts of clonic, myoclonic, and absence seizure. And here is the classical EEG pattern having a fast spike, which is generalized polyspike over the frontal region. Photosensitivity is very, very important in Dravet syndrome. Another patient is in front of you, 8-year-old boy with history of repeated sudden fall causing injury, myoclonus, GTCS, tonic spasm during sleep is there. And this is the classical LGS. It usually begins between 1 to 6 year, intractable seizure up to 100 per day. So multiple seizure types, atonic, myoclonic, atypical absences, and such partial seizure can also emerge. And these are the patients which are refractory to anti-seizure medication, and EEG is slow, generalized, spike and wave, background abnormalities there, activity enhanced during the NREM phase of the sleep. spikes usually have a frontal predominance, and we can also have a slow spike wave paroxysmal, which is important for the diagnosis, and non-convulsive status is also seen in the LGS. A patient who is initially normal, but later on it was not able to speak, there's a aphasia, there is a regression of the social and language skills, there's a have to differentiate from the autism. It is very, very important. And in autism, social skills are in LKS, social skills are better preserved than the autism. This is the genes which are responsible for the development of the LKS, that is the green 2A, and this gene mutation causes the speech area of the brain to be defective, and the speech is not there. EEG abnormality include there is a generalized focal, multifocal spikes, and these are all classical of Landau recognition. And now Panatopoulos, yesterday it was talked, and on the day one also talked, the normal school 3 to 5 years old children, severe nocturnal vomiting, tonic eye deviation, headache, hemiclonus, prognosis is excellent. A lot of elementary symptoms are there, like vomiting and all is there. High amplitude spike from the occipital region is another very, very important, and it has a late presentation also in the form of Gestalt type of occipital epilepsy. That is again a very important. Now this is a very important patient who is in front of, he was brought with abnormal movement with MRI in hand, and EEG in hand showed abnormal discharges. When he came to me, he was already taking this, two anti-epileptic drugs, and patient was kept on Levipil, no response, and now see the movements. He is exhibiting a movement. Do you think that this is epilepsy or epileptic spasm is there? So it is very, very important to see in person, either video or in front of you or eyewitness account. This is very, very important in any patient of whether it is a non-epileptic. Now, see, I have advised him to start the paroxysm. He started that. This is again a very peculiar thing, and so it is a precipitation of the discharger on request. And you will see when I will say yes, now stop the convulsion, he will stop.
चल हो गया, बंद कर दे, है ना, घर जाएगा.
He has stopped. So cessation on request. So this is a very, very important eyewitness account. Apart from EEG, don't go for EEG. Eyewitness account, the sequence of event, the semiology is very, very important. So this EEG was taken in this patient. You can see the artifact, movement artifacts are there. So medicines were stopped, counseling was done. So this is very, very important. EEG is never required in all cases of abnormal movement. So the take-home message from in this lecture is EEG is important assisting tool to your clinical diagnosis. It is a assisting tool to your clinical diagnosis. Make a tentative diagnosis in your mind. Make a clinical diagnosis in your mind. What type of seizure you had and what you have advised for what EEG changes you are trying to see in this patient. Search your anticipation in that tracing which has been ordered, and see where are your anticipation and what is actually the tracing is showing. Your treatment should be driven by the clinical and the supportive investigation, and never alone by EEG. And therefore EEG is a very good important diagnostic tool, but when has to be taken into the consideration of the clinical event, the semiology, the classical history. Don't afford to take the history. Absolutely important in any discipline of the medicine. History, and most of the time, most of the investigations are not required. Thank you so much.
Thank you so much, Dr. Anup sir, for your nice and lucid presentation. And as always, picturesque presentation with lots of videos and pictures to understand. Thank you, sir. I think so. Dr. Anup Kumar sir is ready with his presentation. Anup sir, are you there, sir? Anup Kumar sir.
Anup, your mic is off.
He can unmute now. He can unmute.
Thank you so much.
Okay, sir. Dr. Anoop, sir, sorry. At that point, we were
Kindly
not able to hear you.
share it.
Please.
This meeting is being recorded.
Yeah, are you able to see my slides?
Yes, sir.
Yes, sir. Please go ahead.
Yeah, it was very nice presentation by Dr. Anup Verma sir. He has elaborated almost all the cases of pediatric epilepsy, and now it is very difficult to match up with him, which is not possible at all. So my topic is EEG artifacts. So what is an artifact? It's a waveform of in EEG that is not of cerebral origin. In EEG, we actually record the activities occurring from the cerebral hemisphere, and the artifact they never occur from the cerebral origin. So they are very tiny signals which are electrical noise from many other sources, and artifacts can completely obscure the underlying EEG findings, and it can mislead us to make a different diagnosis. And so we have some ictal mimics, some findings like eye flutter, tongue movement, neurostimulators, head jerks, ventilator artifacts, and psychogenic non-epileptic spells. They actually mimic with generalized epileptic from discharges. In tremors, tapping, focal facial movements, electrode artifacts, they mimic with focal findings. So how you approach with artifacts? Actually, we have to see first appearance. What is the appearance of the artificial wave? What is the morphology, polarity? What is the amplitude and duration, frequency, evolution? And is it disrupting from the background? Or what is the distribution, whether it is limited to a single electrode or it is going beyond the scalp, meaning thereby it is coming in all the electrodes. Whether it is third point, we usually see the whether this is the ambulatory EEG or this is the NICU or ICU EEG or operating room theater. And next point for the evaluation artifact is we have to see the state of the wakefulness, or whether it is drowsy, whether the child is sleepy or comatose. And video recording helps us very much to see whether it is a tremor or it's a patting by mother, whether it's a tooth brushing artifact by the patient while we do the long-term video EEG monitoring, or whether it's a CPR artifacts in a patient who is dying. So what are the clues? There are some clues. These artifacts, they may be limited to the one channel, and they may not be present in the non-contiguous head regions, and they usually affect the non-scalp electrodes. They are having very complex waveforms. Sometimes they are having atypical generalized waveforms, and we should differentiate them from the generalized epileptic from discharges. There will be a precise periodicity and uniformity. In some cases of epileptiform discharges like plaques, we don't get periodicities in epileptiform discharges. And artifacts, they are having very fast, more than 70 hertz, or very slow, less than 1 hertz, as we see in 60 hertz cycles. So artifacts may be of two types, physiological and non-physiological type. In non-physiological, we are having extrinsic or intrinsic. Intrinsic meaning thereby implanted devices in our body, or extrinsic, they are coming from the equipments or environment. So physiological artifacts, they are eye artifacts, ocular artifacts. So there are different types of blink artifact, eye flutter, eye movement, nystagmus, ERG. I'll show all the types. I'm just summarizing the things. Then EKG artifacts, that is pulse artifact, balestocardiographic artifact, arrhythmic artifact or pacemaker artifact, and EMG artifact, swallowing artifact, chewing artifact, bruxism, glossokinetic artifact, movement of the tongue, respiratory artifact, or sweat artifacts. So these are the example of instrument electrode artifact. Electrode artifact like electrode popping, 60 hertz artifact, amplifier artifact, capacitive artifacts, inductive artifact, electrostatic artifacts. There's some movement artifact. The patient moves during the EEG, then the EEG electrodes records the abnormal activities. That is the movement artifacts. So patient movement artifact. So in those conditions, we are having some pathological like myoclonus or clonus. It can be done by the staff of the ICU or the EEG room in the form of external rub or suctioning. So first we start with the eye blink artifact. What is the cause of eye blink artifact? We usually know that cornea has got some more polarity than the retina, and FP1 is more closer to the cornea. When eyeball moves upward, then there is more positivity towards FP1 and less positivity towards FP3. So we get the negative deflection, which is the positivity in the EEG, and less positivity seen in the F3C3. So this is an EEG tracing which is clearly depicting the eye blink artifacts. So we can see the eye blink artifact in the frontal leads mainly. This is FP1, F7, FP1, F3. Then we can see in those left side, and they are the right side blink artifacts. There are lots of artifacts. There is no periodicity. This is on the will of the patient. These are the eye filtering during photic stimulation. We usually give a provocative technique we apply during recording EEG, that is photic stimulation, and with the flashing of the light, eye blinks in very fast manner. So this you can see the repetitive eye blink artifact, which is in this case it is which is the eye flutter. Now another type of the eye movement artifact is the lateral eye movement artifact. That was the vertical movement artifact, and this is the lateral one. So in this case, when both the eyes moves in the same direction, so when the patient is seeing on the right side, the cornea moves towards the F8, making more positivity than the FP2, and in the left side it is moving away from the F7. So there is more positivity towards F8 and the less positivity towards F7. Here you can see these are the slow lateral movement eye artifact. You can see the positivity in the negativity towards the F7 and positivity towards the F8. These are the typical lateral eye movements. They are somewhat lesser steeper than the proper eye blink artifact. These are the nystagmus movements. When there is classical fast and slow component of the eye, then you can see the steep curve and the slow recovery, steep curve and slow recovery. And you can see the multiple these type of the nystagmus artifact. And they are usually limited only in the frontal leads, not the posterior leads. Here you can see the lateral rectus spikes, which are more towards this anterior temporal leads, which are the F7 on the left side and F8 on the right side. These are the lateral rectus spikes you can see. So another electrode artifact is electrode pop. So this electrode pop, this is the longitudinal electrode arrangement, that is 1, 2, 2, 3, 3, 4 and 4, 5. When we get the fast upswing and slow decay, which is highly suggestive of electrode popping with no voltage change in adjacent electrodes. Here we can see there is clear-cut deviation from the normality which is limited to the 2 to 3 and 3 to 4, and they are kissing each other. So this is, we can see the third electrode is the common. So we can clearly see there is the movement artifact or popping of the electrode in the third electrode, not in the first, second or fourth electrode or fifth electrode. So this is the classical example of electrode popping. You can see F7, T3 and T3, T5. This is occurring in the T3 electrode. It is not occurring in this channel and in this channel. So this is classical electrode popping. So you can see in the P4 region repetitive popping, and they are the mirror image of each other and they are kissing each other. This is the classical popping. You can see these fast components or this is a faster activity which is limited only to the FP2 electrode. So this is also the electrode artifact, which is only limited to the FP2 electrode. If it is happening in the F4 electrode, so this might have also come here in the F4, C4 and F8 and T4. So what is a single bad electrode? Single bad electrode, when meaning thereby when there is continuous electrical artifact coming from the single electrode. So here you can see the FC, F3, C3 and C3, P3, and we are getting the continuous bad discharges from the C3. So this is a single bad electrode. Now there are lots of artifacts occurring from the muscles, and then this is the classical example of repetitively firing motor units. And you can see these are the temporal electrodes, anterior-temporal electrodes, and you are seeing the repetitive firing motor units. These are the very sharp contour, which is not looking like a spike or anything else. Now you can see that this sweat artifact. When there is sweat comes between the electrode and the skin, there is somewhat slight disturbance in the background, and you can see the misalignment of the electrode and skin, and there is a deviation of the basal electrode line like this and this. You are seeing at the arrows. Now another type of the artifacts are EKG, electrocardiographic artifacts, which are very rhythmic to the this pulse rate, and they are very much in interval with each other, and they are very rhythmic. They are coming at the regular interval. You can see these are the EKG artifacts, and if we are able to see, they are the EKG, and they are clearly matching with these artifacts. You can see here, which is classically matching with the QRS complex of the EKG. Now you can see the pulse artifact, which is classically matching with the EKG. They are the pulse artifact which is occurring in the F7, and they are the mirror image of each other, and they are kissing each other. So this is the 60 Hertz artifact, which usually comes from the electrical system. In India, it is not 60 Hertz, it is 50 Hertz, but in the books it is described as 60 Hertz due to the books published in the Western countries. In India, we usually get 50 Hertz artifact, and it is eliminated by the changing the notch settings. We are the classical sinusoidal pattern, which is more than around 70 Hertz. This is very less. They are very much constricted, and they are very faster activities. Whenever you change the notch setting, they usually disappear. So you can see the ventilator movement artifacts. Whenever there is a when you use in NICU high frequency oscillator ventilators, HFO, then you will get the high frequency artifacts. They are looking like 60 Hertz, but they are not 60 Hertz. They are due to high frequency ventilation settings. Whenever you off the ventilator, they will usually disappear. So you can see the regular spike and wave pattern here, but these are not true spike and wave. These are the patting artifact when the mother pats the baby while doing an EEG. And you can see the regular occurring interval. So when the mother stops patting, then the child starts crying, and then you can see the crying artifact in this slide. So another type of artifact is hiccup artifact. In this, we can see that when the child, the patient is lying towards the right side, then you can see these regular artifacts on the posterior side of the right side. Here you can see, here you can see, and here you can see. They are the chewing artifacts occurring mostly in the temporal regions, occurring from the temporalis muscles, but they usually present in all the leads, not limited to only to the temporalis muscle. But in case of bruxism, they usually limited to the temporalis muscle electrode artifacts, they are not present in the central and midline electrodes like FZ, CZ, CZ, PZ. They are absent in those cases. And the duration of the hypersynchronous firing or the high faster activity is broader than the chewing artifact. Now, whenever you move the tongue in and out or side by side, then you get these type of the artifact. These are the glossokinetic movements. So, whenever you get a myoclonus, there is a movement of the body in a synchronized manner or asynchronized manner, both, and you will get very sharp contour the movement artifact of the body in case of myoclonus, as the time duration of myoclonus is very less, and in that manner you will get the very lesser duration myoclonus artifact. So these are the artifacts. They are occurring in, usually you can see in the ICU setting whenever there is a comatose patient and you give the external stimulation to wake up the patient. So you will get these type of the external rub artifacts. These are the artifacts whenever you do suctioning of the patient in which the EKG is going on, then you can get these type of the irregular arrhythmic type artifacts in the EEG. So you can see the toothbrushing artifacts. This is very interesting. Whenever we do the long-term video EEG monitoring of the patient, which is of 24 hours or overnight stay, then next day morning the child is going for the toothbrushing, then you will get the continuous firing in the temporalis muscle electrode. Like these are the temporal electrodes, and you will get the faster activities. Now these are the classical. Dr. Anup Verma sir has just described the case of the psychogenic non-epileptic case. So these are the somewhat depiction of that only, where the child starts shaking and shaking stops. So artifacts, they usually stops with the movement, with the stopping of the movement of the body. So this is clearly saying before the movement EEG was normal, after the movement EEG was again normal. So this is classical psychogenic non-epileptic spell. These are the rhythmic CPR artifacts. Whenever you do the rhythmic CPR chest compression, so there will be the CPR artifact on the EEG. So these are the breach artifact. What do you mean by breach? Breach meaning thereby when there is absence of the scalp bone. Whenever you do the any operative procedure on the head, and if there is loss of bone from that area, then you will get the faster activity on that area. Here we are having the faster activity in the temporal region. So this is the breach artifact. Another artifact seen in the ICUs are the ventilator tubing artifact. You can see the regular artifact occurring from on the irregular interval according to the settings, ventilator settings. Yes, these are very interesting artifacts. Whenever the patient is having phone in their pocket, or doctor is having, or technician is having phone, and whenever cell phones rings, then you can get these type of the artifacts. They are the classical cell phone artifacts. So whenever you do EEG, please take care of that. You should not have these mobile phones in your pocket, and they should be kept aside. So how do you reduce artifacts? So we do the manual rejection and automated artifact rejection. Subtraction methods are present in the EEG machine, and band pass filtration we usually use to that. So these are two types of the when lower frequency filtration and upper frequency filtration. You can see these are the low frequency movements, 1 to 2 hertz or 0.5 to 1 hertz around. And when you increase the low frequency filter to 5 hertz, these movements, they disappear from the background. So you can do you can apply some technique to overcome the artifacts. In this high frequency filtration is there, and you do the when it is 70 hertz, and you pick up all type of the artifacts, and when you reduce this high frequency filter to 15, these high faster active, they usually disappear. So you can use these band pass filtration method. The same example is also shown here again. So conclusion for today's presentation: the EEG artifacts are commonly encountered in ICU or in EEG rooms, and they can be easily identified. But sometimes they are very much difficult to identify, and they mimic the brain activity, including interictal findings. And you should remember that video is very much helpful in identifying the source of the artifact. So I recommend, don't go alone with simple EEG. Always ask for the video EEG. In my EEG room, I always do all video EEG in all the cases, whether it is demanding or not. Then identifying and interpreting EEG artifact is essential to proper EEG interpretation. That's truth. And artifact reducing technique should be applied. But you should keep the basic principle of identifying an artifact in your mind. And whenever possible, attempts should be made to rectify the source, and all the artifactual substances, they should be removed from the site of the EEG. Thank you so much.
Thank you, sir, for a nice presentation and in time presentation, sir.
Thank you.
And I think so. Anyone wants to ask any question? If anyone can ask the question. We have 2, 3, 4 minutes.
I think audiences has learned everything.
No. Thank you, Dr. Anup. You have elaborated so much. Still, I don't think that without going into proper demonstration of artifacts, much interest will not be generated in the delegates. Okay, that is there. But to be very frank, while you are doing any case, what personally do you do to remove the artifact? अपनी टेक्निक में हम लोग क्या क्या और कर सकते हैं कि आर्टिफैक्ट्स कम हो? मैं अपनी बात बताऊं। हाँ, हेलो, am I audible now?
Sir, you are audible. Please carry on.
हाँ, मैं क्या कह रहा हूँ कि जब मैं करता हूँ EEG, तो ऑन एन एवरेज 10% टाइम तो वो आर्टिफैक्ट आते रहते हैं। वो मूवमेंट आर्टिफैक्ट भी होते हैं, कुछ वोल्टेज पता नहीं, कहना मुश्किल है, लेकिन ये है कि मे बी लूज अटैचमेंट ऑफ इलेक्ट्रोड्स, मोस्ट लाइकली कॉज इज लूज अटैचमेंट ऑफ इलेक्ट्रोड्स। तो इलेक्ट्रोड्स के अटैचमेंट को और इम्प्रूव करने के लिए क्या राय देते हैं आप?
सर, इलेक्ट्रोड का अटैचमेंट हम कर सकते हैं। जैसे लोग क्या करते हैं कि जो इलेक्ट्रोड है उसमें आपने पेस्ट लिया और डायरेक्ट अप्लाई कर दिया।
हाँ,
उसके बजाय पहले ये चेक करना चाहिए कि उसके जो पेशेंट है उसका सिर में ऑयल एप्लीकेशन तो अप्लाइड तो नहीं है।
नहीं, शैम्पू करा के आया।
हाँ, शैम्पू करा के आया है, तो उसके बाद उसका जो पहले हमें जिस पॉइंट पर हमें इलेक्ट्रोड लगाना है, पहले वहां पर फिर इलेक्ट्रोड में पेस्ट लेकर फिर उसको चिपकाया, उसके ऊपर से कॉटन लगा के उसको अच्छे से प्रेस कर, जिससे कि एक स्नग आपस अपने आप में अटैचमेंट डेवलप हो जाए।
अच्छा, ऐसी बात है, जैसे मान लो आपका अगर पेस्ट खत्म हो गया है, तो लोग कहते हैं मुल्तानी मिट्टी, क्या उसका क्या है सेम इक्वल इफेक्ट है?
सर, इसकी एक टेक्निक होती है, इसको पेस्ट को बनाने की। 2 तरह के पेस्ट आते हैं, 10-20 पेस्ट आता है एक, और एक सर मिट्टी का वाला बेस्ड जो होता है, जो चौक मिट्टी बेस्ड पेस्ट होता है, वो आता है। मुल्तानी तो नहीं इस्तेमाल करते, चौक मिट्टी से बनता है वो पेस्ट। तो ये 2 तरह के पेस्ट होते हैं और दोनों ही फ्रूटफुल हैं। ऐसा नहीं है कि एक अच्छा है एक बुरा है, पर ऑब्वियसली 10-20 वाला पेस्ट ज्यादा अच्छा है, क्योंकि वो महंगा भी थोड़ा सा है और उसके थोड़ा टेक्निक जो है बनाने की वो बहुत डिफरेंट टाइप की है। so that is better, but you can do with the chalk mitti as well. You
अगर
can, you
टेस्ट
have to mix something else that to make a paste.
अच्छा, वो आप लोग अर्थिंग अलग से करते हो कि नहीं? अर्थिंग
हाँ
करते
सर,
हो?
अर्थिंग करनी पड़ती है अलग से, इसमें गोल्ड की, उसकी कॉपर की अर्थिंग करनी होती है। अराउंड 6-7 मीटर नीचे की तरफ कम से कम 1 किलो का कॉपर का शू बना के डालना पड़ता है। और उसके बाद ये हम कोशिश ये करते हैं कि जो बेड है हमारा वो भी लकड़ी का हो, आसपास कोई भी इलेक्ट्रिकल नॉइस होने वाली कोई भी चीज ना हो। जो वॉल्स है वो प्रॉपर अपनी ईंट वाली वॉल्स होनी चाहिए। ऐसा नहीं है कि हम जो एल्युमिनियम सेक्शनिंग में बैठ के ये सब काम करें। प्लस कहीं पे भी जो बेड है आपका या पेशेंट का जो पार्ट है किसी से टच नहीं होना चाहिए, सेल फोन नहीं होना चाहिए, सेल फोन सब बाहर होने चाहिए। Even then you get this grounding artifact, then अपने कंप्यूटर सेटअप को चेक करना चाहिए कि कभी-कभी उसमें क्या होता है कि जो एसएसपीएस होता है जहां से इलेक्ट्रिकल सप्लाई आ रही होती है वो वहां से आर्टिफैक्ट जनरेट हो रहे होते हैं।
अच्छा, और आपने बताया स्लीप आर्टिफैक्ट्स के बारे में, तो स्लीप आर्टिफैक्ट्स में और क्या-क्या चीजें हम लोग ध्यान दे सकते हैं?
नहीं सर, आप दोबारा पूछिए क्या पूछ रहे हैं?
ड्यूरिंग जो एक स्लीप, जो एक आर्टिफैक्ट जैसे आई मूवमेंट आर्टिफैक्ट स्लीप में भी आप अगर है, अगर वो लाइट स्लीप में है आपके डोज देने के बाद या प्रोसीजर करने के दौरान वो जाग गया, थोड़ा हिल गया, तो उसके बीच में आप उसको फिर से इलेक्ट्रोड को चिपकाने के रोक कर उसको दोबारा दबा के करते हैं या उसी को कंटिन्यू करते हैं?
नहीं सर, उसको रिपोजिशनिंग करते हैं। कोई भी इलेक्ट्रोड, अगर इलेक्ट्रोड पॉपिंग इज देयर, हम वी यूजुअली रिपोजिशन दिस electrode and then we get a better result.
प्रैक्टिकली कितनी देर का आप एक ईईजी सेशन करते हैं? मिनिमम कितना?
सर
आइडियली 1 आवर, बट प्रैक्टिकली?
Sir, practically I used to do for 30 minutes, but there are lots of many types of the EEG, like short-term video EEG, which is of 4 hours, long-term video EEG, which is overnight stay or 24 hours. So there are multiple type of the techniques are there.
Normally what yes, normally what this am I audible?
Yes sir.
Yes sir.
Normally what is recommended is around 20 minutes of EEG in a child, and for a neonate it is at least 60 minutes. And regarding Anup has said the earthing and various artifacts and all, the most important thing is the technician who is doing the EEG. Previously, when we started doing EEG in 1994 somewhere, we have a huge setup of analog EEG machine, and various stylus was there with key ink like that, and used to have broad papers. We have to purchase a huge paper, EEG papers from the Chandigarh Medicaid and Medicare, and then a lot of artifacts were picked up at that time. A lot of voltage fluctuation were picked up. So it was from there we have, from a huge machine, we have now landed with a very small machine which we can hang the machine in hanging the drip stand. So the technique as that, but then definitely our technician is very important. He has to note that yes, he has shaken the head, he has the moment.
At this time, I would like to share what EEG machine I have. This is this set only. You can see this is simple a board.
हाँ,
okay.
that's all. हाँ, इतना ही रहता है. ये आपके पास कौन सी वाली है? मेडिकेड है, मेडिकेयर वाली है? ये अपना इसकी अपना
न्यूरो कॉम्पैक्ट
वाली. ओके,
न्यूरो कॉम्पैक्ट
वाली.
हाँ मेडिकेड वाली. ये मेडिकेड का है क्या? ये हाँ मेडिकेड की है. तो बस यही सेटअप है सर आजकल, एकदम छोटा सा.
मैं तो इसके फैक्ट्री में गया था 1994 में. ये बंदे के यहाँ मैं चंडीगढ़ गया था, इसके यहाँ मशीन देख के आया था, पूरा फैक्ट्री देख के आया था.
और ये
बंका करके था वो, अभी है नहीं मालूम.
सर मेडिकेट है, बाकी सारी कंपनियां भी पैदा कर दी, बाकी क्लैरिटी पैदा कर दी.
क्लैरिटी भी अच्छा है, क्लैरिटी भी अच्छा है, आरएमएस भी अच्छा है.
सब मेडिकेट का ही पार्ट है सर.
हाँ वही. नहीं, पर बाहर की मशीन भी बहुत अच्छी हैं जो बाहर से आ रही हैं. दे आर वेरी कॉस्टली, It is good for institutions.
आज
Thank you very
कल
much.
मिलते हैं हम लोग अब।
This meeting is being recorded.
डॉक्टर अनूप वर्मा सर, रिक्वेस्टिंग यू वंस अगेन कि आप अपना देखो प्लान,
चलिए मैं
अगर हो तो हम लोगों को बताइए। वी आर ईगर टू मीट यू।
श्योर श्योर श्योर।
लखनऊ में आपको आए हुए हो गए 7-8 साल हो गए।
हाँ हाँ, वो अपने आशुतोष ने बनाई कराई थी ना। अब अभिषेक था,
हाँ।
अभिषेक थे और
अभिषेक
अपने
आशुतोष
चावला
थे।
चावला साहब थे।
7-8 साल हो गए।
हाँ, उन्होंने काफी अच्छा ऑर्गेनाइज किया था। रस्तोगी थे, काफी लोग थे। नो अभिषेक, यू वर देयर नो?
Yes, sir. Yes, sir. I was there only. Sir.
हाँ, या आई नो, आई रिमेम्बर ऑल है। थैंक यू सो मच, थैंक यू वेरी मच।
सर आप
Thank you so much.
मैं बताता हूँ अजय।